I'll give it a couple more minutes. I think we have people coming in. Including our illustrious president. Okay. Oh, I think it's a couple of minutes after. I think we'll get started. And I wanted to open by saying thank you for attending this webinar, which is the second in our third series of Chronicles of Wound Scene Investigations, which is open to all at no cost. Please note, if you have any questions throughout this evening's presentation, use the Q&A box and we'll address as many questions as possible at the end of the webinar if they're not addressed in the presentation. And as a reminder, this webinar is being recorded and will be available after this presentation on the Wound Healing Society website for those who are members. As a brief introduction, which I guess I should have started with, my name is Kath Berge. I'm the chair of the Education Committee, and I will now pass you over to the moderator, Dr. Tugba. I won't mess up your last name.
Okay, hi everyone. My name is Tugba Ozdemir, and I am an assistant professor at South Dakota School of Mines, Nanoscience and Biomedical Engineering Department, and I will be talking about the question and answers after the end of the webinar. Yes, Christina.
Hi, everybody. I'm Dr. Christina Megal. I'm an assistant professor at the Medical College of Wisconsin. My training by background is as a nurse practitioner, and I serve in the role as a clinical director of our wound care center and inpatient and outpatient program.
Good evening, everybody. My name is Irena Pastar. I'm associate professor at the University of Miami Department of Dermatology. My background is molecular microbiology, and my research focuses on host pathogen interaction in skin and wound infections.
All right, let me share our screen and away we go. All right, good evening, everybody. Thanks for joining us on this chilly, very chilly January evening. Topic today is MRSA, skin and soft tissue infections and abscesses. We're going to look at clinical presentation, and then Irena is going to go through the amazing ways that MRSA has adapted to becoming quite the pathogen that it is, and the enemy of many of us in the wound care world. So first, what's the epidemiology and the transmission of MRSA? What do we know about it? Well, it's very easy to track what happens in the hospitals. We have infection control departments, we have data, and what the CDC has published is that about 5% of all hospitalized patients are positive for MRSA as MRSA carriers. Now, community-acquired MRSA is much, much harder to quantify, so we don't really have a feeling for what the percentages are, and it's going to vary by location throughout the country. As far as transmission goes, it's most often spread by that direct person-to-person contact. It's usually skin to skin. And this is where that hand hygiene practice in the clinical environments is so desperately important as the #1 prevention step for spreading. We can also have contact with contaminated wounds. Obviously, we come into contact that as wound clinicians on a daily basis. Personal items, less likely to spread MRSA, but things like towels and razors and sports equipment that's shared amongst athletes can also be a cause of spread. Generally, the environment is lower risk as opposed to that human-to-human transmission. All right, what are the risk factors? There's 3 major groups of risk factors. We have the healthcare exposures. So we have the folks who are recently hospitalized. We have our long-term care residents, recent surgeries, hemodialysis patients, just those frequent interactions in the healthcare environment. We have environmental exposures. So we know individuals who are incarcerated and prison guards who work with those individuals have a much higher risk. Military service, close quarters, not always attending different school environments, living in crowded conditions. We talked about the sports equipment, and then sharing needles, razors, or other sharp objects. And then the third category is patient specific. So we have people who have known MRSA colonization. They've had recent close contact with a family member or a person with MRSA. HIV folks are more likely to be infected. Drug use, homelessness, and then antibiotic use predisposes people to MRSA. So what's the pathophysiology? When somebody's susceptible, so we have a susceptible host, what happens when MRSA starts to take effect in the body? So the first thing we have is that bacterial breach. Somehow the bacteria has gotten onto the skin, it's breached the epidermis, and it's started that very initial immune reaction. We have a cytokine and a neutrophil response coming to that area. The epidermal response proceeds, and it includes the production of antimicrobial peptides and then keratinocyte proliferation at the site. So we start to see those changes, those early clinical changes. This then progresses to that cellulitis or abscess characterized by very poorly demarcated erythema. So we start to see that creeping redness from the area with warmth, edema, and tenderness to palpation. Constitutional symptoms that a patient may report are often generalized malaise, just overall fatigue, along with fevers. So on a history and physical, we're in the clinical environment now. We've got somebody in front of us. We have some suspicions. What do we want to know, or information do we want to gather? We want to ask, how did those changes begin? Did it start with a pustule? Was there any injury to the area? And just how did those skin changes begin? Any recent travel, trauma, IV drug use, insect bites, or any other risk factors that we touched on the other slide? Does the patient have a past medical history that predisposes them to infection? Any history of skin breakdown or trauma to the skin in that area? We may also want to consider, if we're starting to see that erythema, demarcating that area with a surgical type marker so that we can track the progression and the rapidness of the progression over time to know if our therapy is going to be adequate or is adequate while it's undergoing. We want to palpate. We really want to touch that area and palpate for any fluctuance, abscess pockets. We're looking for that heat and that tenderness that's so common. For foot and leg infections, very critical to check between the toes, because those fissures that can occur between the toes can often be the cause or the site of infection. All right, so we've met our patient, we've done our history and physical, we're pretty sure that we've got an infection going on. So what are our clinical guidelines that exist to help guide us? The Infectious Disease Society of America has clinical practice guidelines for MRSA. They were last published in 2014, and there hasn't been any updates since. I did include the reference in the slide for you. It's a very long clinical guideline. There's a ton of great information in there. I just wanted to pull out 2 pearls for this evening's talk. First, on purulent skin and soft tissue infections and those guidelines, and second, the recurrent abscesses, since that's pretty much our focus for the evening. So in the purulent skin and soft tissue infections, the guidelines do state cultures are recommended to guide therapy to make sure that we're choosing that right antibiotic for the right bug. And this comes with fairly moderate to strong supportive evidence. The next thing that's recommended is that IND. We want to have that incision and drainage to get that material out of there. We want to probe that pocket, make sure we're breaking up any loculations to get all of that accumulated detritus out of that pocket. There is research that shows needle aspiration is not effective in MRSA. In 2010, there was an emergency department that did a study with an N number of about 108 patients. They compared the two techniques and found that with community-acquired MRSA abscesses coming into the ED, only 8% had a cure rate when needle aspiration was used, compared to 55% with the INDs. Now, the question is, when do we do antibiotics? What the guidelines state is that antibiotics directed against Staph aureus are based on the presence or absence of SIRS, the systemic inflammatory response syndrome. So this currently entails a temperature greater than 100.4 Fahrenheit or less than 96.8, increased respiratory rate or tachypnea greater than 24 breaths per minute, tachycardia over 90 beats per minute, and a white count of greater than 12,000 or less than 400. So we need to be meeting several of those criteria for SIRS to be present. In that case, antibiotics are recommended against S. aureus. What the research has found and the guidelines state is that systemic antibiotic without the presence of SIRS does not improve cure rates. The IND is enough in those cases. Now, if we have a patient who has impaired host defenses or they've failed initial antibiotic treatment, antibiotics directed against MRSA are recommended. All right, so let's take a look at recurrent abscesses. What do the pearls say here? So here we want to search for local causes, such as a pilonidal cyst, hidradenitis suppurativa, or other foreign material that's triggering recurrent abscess sites. Early drainage and cultures are recommended for these patients. And then based on the culture result, either a 5 to 10 day course of antibiotic active against the pathogen is critical. Now, some lower evidence things, but these are in the guidelines, is to consider a 5-day decolonization regimen twice daily of intranasal mupirocin ointment, daily chlorhexidine washes, generally from the neck down because of its harshness on the face, and daily decontamination of personal items to help stop spread the infection of the MRSA. If we have adult patients who have these repeat skin abscesses, they should also be evaluated for neutrophil disorders, especially if they began early in childhood, because what's happening with their immune system, we'd really like to know. This slide I included because the CDC, in combination with the AMA and the IDSA, has compiled a very good collection of informational posters for clinicians. This is an example on the left of the outpatient management of MRSA. There are posters for sports themes, for childcare and education professionals. It's an excellent website with very readable and very usable materials. So it's just a good resource to be aware of. All right, moving forward. So now we have a patient we have diagnosed with MRSA. We have an IND, we possibly have a wound, and in the case study coming up, we do have wounds that we're going to need to manage related to this. One of my responsibilities in my role in the wound care center was to bring forward a chronic wound care protocol that we could follow and utilize guidelines to make sure that we're providing best standard of care for those wounds, regardless of whether they're MRSA or not. So this is based on the 2017 biofilm-based wound care model that was published. This was our adaptation of it. And essentially what we're doing is we're making sure the time principles of wound healing are coming through. So tissue management, infection and bioburden control, moisture management, edge care, making sure that everything is, and then it's rechecked, and we step up and step down with antibiotics as needed to make sure that the patient is responding appropriately. So here's our case study. In this situation, we have a 24-year-old male. He has a history of type 1 diabetes mellitus with Moriak syndrome. Interesting syndrome. It's rare. It's diagnosed in children at a young age who have had very poorly controlled type 1 diabetes. And it contains the spectrum of challenges. So there's growth retardation. This particular patient is 5.5 feet tall. He had delayed puberty, Cushingoid features, hypocholesterolemia, hepatomegaly, and then they have pathological glycogen storage in the liver. So he's already dealing with some challenging issues just with the diabetes and the Moriak syndrome. Additional healthcare problems he has is anemia of chronic disease, hypertension. He has the superior mesenteric artery syndrome, gastroparesis, and he has a placement of a jejunostomy tube for nighttime feedings to supplement his nutrition. And he does have that past history of abscesses. His most recent one was on one of his hips back in August of 2022. And that particular abscess was positive for MSSA and group B strep at the time. He has a mental health background as well, oppositional defiance disorder. So cooperation in treatments can be challenging. His BMI is low. You can see it's 14, goes along with the malnutrition diagnosis. And as far as support, he lives at home with his mom and his siblings, but he is decisional for himself. So how did he present to us? He presented in June of 2023. He was scheduled at an outside facility for routine EGD, but on arrival, they checked his blood sugar and it came back at 600. So they transferred him to the emergency department for evaluation, found out he hadn't been taking his insulin for several days or checking his blood sugars. And he mentioned, oh, by the way, I think I have an infection in my groin on his leg. So he points to his inner thigh area. The ED diagnoses him with diabetic ketoacidosis, hyponatremia, acute kidney injury, and sepsis during this visit. So this is the initial presentation. You're looking at the upper inner right thigh. You can see some of those skin changes. We have some desquamation as the skin is sloughing off. It's hot to the touch. There's a lot of erythema and very, very painful to the touch. His white blood cell count came back at 23 and his H&H low at 7.5 and 24. So he's got that anemia of chronic disease, but here we have a high white count. So he's meeting that SIRS criteria with that particular criteria. They did a CT scan and it revealed soft tissue edema and swelling of the medial proximal thigh with skin thickening and soft tissue edema. They did not see any evidence of necrotizing soft tissue infection, which is always another concern when you have infection in the soft tissues. They did see lymph nodes that were prominent. So 3 days later, you can see the picture on the left shows we have a progression of that area, particularly on the the buttock is to the left, the posterior leg is a little bit more to the right. But these areas are getting firmer, they're still hot, there's more fluctuance presenting itself. So he makes his first trip to the OR and they address the buttock site first with an IND on that one. That left about a wound of about 2 by 3 centimeters with several centimeters of depth that required packing. He made another trip to the OR on June 30th. Again, there was more tissue necrosis present. So he had his second IND, which left him with the inner thigh abscess, about 5 by 4 centimeters. They had to take out both muscle and fascia from the necrosis. And then on the buttock, the thigh buttock area was 3 by 3 centimeters. And you can see that there's still some necrosis in the base of that tissue. They sent the tissue for culture and it grew both Candida albicans and MRSA. Again, with those high sugars, and we don't know how long he was having the high sugars, not only probably promoted the growth of the MRSA in the high sugar environment, but the fungus was present as well. Antibiotic therapy. So inpatient, he had linezolid and Zosyn. He had good response from that. By 6:30, his white count had decreased, so they transitioned him over to some oral antibiotics. From the wound care side, we were using topical dressings that had methylene blue, gentian violet packing to help with that surface antimicrobial. At his first outpatient visit, they updated his dressings to a ionic silver hydrofiber dressing daily to see if we could get a little bit more cleanup. And the wounds looked pretty good. What I noted when I was looking at this photo and this particular visit is the surrounding skin looks so much better. Like he's had regrowth of that healthy tissue, and now the wounds are very clearly demarcated and we can see where they are. And hopefully the idea at this point was to promote as much healing as possible. However, 1 week later, he presents and he reports that he had a temperature of 102 the previous night, and that a large mucinous or fibrinous mass, as the patient described, kind of was retrieved from the wound. So there must have been some accumulation of drainage. On exam, copious purulent drainage was present. Patient was not feeling well, pulse of 138, low blood pressure. So again, he was meeting criteria of SIRS, so he was admitted to inpatient for management. This CT scan showed a multilobulated collection of fluid and air in the right abductor muscle group of the pelvis extending into the posterior thigh, much worse compared to the first CT scan in June. So you can kind of see that on the left of the picture compared to the right. There's just a large collection of accumulation in this particular view. He underwent further surgical debridement on July 16th. You can see that the surgeon chose to make 2 additional openings that allowed that tract, the purulent tract, to completely drain, and put in these space holders to allow them to remain open and drain appropriately. At this point, we were, well, all along we had been using hypochlorous acid as our standard of care for wounds, again, to help with that decontamination or just bringing down that bacterial count in these wounds. Drains were removed finally July 28th. He did have several complications in his hospitalization, including aspiration pneumonia. So antibiotics were continued, more so for the pneumonia, and was discharged again with the methylene blue and gentian violet dressings in place. But again, getting smaller, looking better. Readmitted for complications related to the pneumonia, and at this point in time, they restarted an antifungal, and the wounds really started to look a lot better once they were doing the combination therapy. Leg wounds were progressing here with no further necrosis, and there weren't any further surgical follow-ups for this patient, but he did have a follow-up with his primary care on November 2nd, where they were kind enough to take a picture for us, and we were able to see that he was able to heal to resolution at that point. So key success factors in the management of this patient was really, looking at those host factors. He had a lot of risk factors. He had the hyperglycemia. We had to correct the malnutrition, all those hospitalizations that he had. Very aggressive antimicrobial therapy for those identified organisms. And then we really focused on both that topical approach from the wound care using frequent debridement, the right type of dressings with appropriate antimicrobials, moisture balance, and that edge care, along with repetitive debridement courtesy of our excellent surgeons. So questions to ponder as I turn it over to Irena is, what makes MRSA so detrimental to wound healing? And what mechanisms has this tricky little MRSA bug developed to ensure its own survival? It's a crafty little guy.
Next slide, please. Thank you, Christina. Wonderful introduction. And yes, indeed, we'll be talking about and covering what makes MRSA so virulent and thriving in skin, in wound environment, and contributing to a significant number of mortality in US caused by this superbug. So in a nutshell, MRSA or MSSA, so both methicillin-resistant or methicillin-sensitive Staphylococcus aureus, actually make a good component of our microbiome. Next slide, please. And we see it in all the different parts of the bodies. So this is, we are looking here at the composition of all the microbiomes sharing our skin and using it as a habitat. And the composition does vary from the body location and also from individual to individual. And as you can appreciate here, based on different colors of the stock plots. So as we are moving down to the plantar heel, to the leg, we actually see more and more of Staphylococci species. And I'm pointing here at the orange that we actually see at these graphs. So Staphylococcus aureus in the normal conditions actually shares skin as a microenvironment with other microorganisms. And even with the good Staphylococci species, such as Staphylococcus epidermidis, Staphylococcus hominis, or even Cutibacterium acne. And all these good commensal bacteria are in a way keeping Staphylococcus aureus in a less virulent state and protecting the skin from the infection. Next slide, please. However, what makes it really potent and what makes both MSSA and MRSA capable to overcome host defense and to overgrow other beneficial bacteria are the platform of the virulence factors. So Staphylococcus aureus produces a lot of toxins, invasins as well, that can overcome our host immune system, human immune system. It also attaches very nicely by using adhesins to different cells in our organisms, and it can overcome immunoglobulins, the response of our B cells, by actually blocking them with the protein A. And on the right side, I'm showing example of how one of the most potent toxins, valentin leukocytes, works on the host cell. So it's basically poking the pores on the cell and causes necrosis. It causes inflammatory form of cell death by secreting this toxins in the virulence factor. Next slide, please. So we will go over a few major virulence factors. Among the other exotoxins that Staph aureus makes, we have platform of the hemolysins, which can lyse red blood cells, leukocytes, and even muscle cells, then leukocidins that can lyse neutrophils and macrophages, different enterotoxins, then exfoliative toxins as well, which can actually cause desquamation. And they're chopping the surface protective layers of our skin, causing staphylococcal scalded skin syndrome. And then staph also can cause toxic shock, as we know, by the toxic shock syndrome toxin. So let's go to the next slide, an overview. Invasins, these are the exotoxins that Staphylococcus aureus secretes and can coagulate blood plasma, also digest connective tissue, which allows Staphylococcus aureus to invade underlying tissues, like we've seen in the patient Christina presented. They can digest blood clots, digest even oils, and help all these digestion processes actually help Staphylococcus aureus grow and thrive within our body. And then it is also equipped with the multiple mechanisms to overcome and inactivate antibiotics. In addition to this, Staphylococcus aureus, it's really good in attaching to our cells, skin cells, muscle cells, and so on. And that will be of importance of overcoming additional host immunity. Next slide, please. However, the results of infection really do depend on the disbalance of the virulence factors and the host immunity. So in addition to systemic conditions and that were nicely outlined in the case report, skin also is equipped with a local defense mechanism. So our skin produces the different antimicrobials, defenses, catalysidins that actually have a broad spectrum of antimicrobial activity to also even resident cells such as keratinocytes can actually serve as the initial source of antimicrobial peptide secretion. And then our skin, briefly after the barrier is breached, briefly after wounding, gets inflamed by neutrophils and macrophages that kill microorganisms by phagocytosis. In addition to this, we also have local immune cells residing in the skin, dendritic cells that are serving surveillance of the invading pathogens, and then also Langerhans cells that are antigen-presenting cells. Next slide, please. And host defense, systemic host defense is, of course, very important. So systemic factors that increase the risk of MRSA infection are the ones that were mentioned earlier, including the diabetes, alcoholism, vascular disease, and then also previous surgeries and previous conditions. And what is really striking, next slide, please, is that even without any wounds or the skin condition, simply diabetes can actually change the populations of the Staphylococcus aureus and change the composition of the skin microbiome. So what we are looking here is the control arm and diabetic arm of patients where we don't see much of the change in the microbial composition or the prevalence of Staphylococcus aureus. However, when it comes to the foot, the scenario changes quite a lot. So just with the prevalence of diabetes, even if it's controlled diabetes, that allows for the overgrowth of the Staphylococcus, and it was actually shown that this overgrowth results in predominance of Staphylococcus aureus, while other Staphylococci species, including those that are potentially beneficial, are decreased. Next slide, please. And now you can imagine what happens when this area, when the skin is breached and the wound is open. Well, we know very well that every wound will be colonized. So from the surrounding microbiome, from the environment, once the barrier is breached, microorganisms get the opportunity to invade the skin and the organism. However, this is tightly controlled by inflammation, and that's the reason that the inflammatory phase is the first one and the most important one in the context of successful wound healing. And it's triggered very early on by cytokine interleukin-1 beta made and pre-stored in epidermis, which then triggers plethora of these growth factors and cytokines that coordinate communication between different cell types and assure not only successful bacterial clearance, but also progression to the next phases of the wound healing. And the next slide. However, in the chronic wound environment, we actually have the problem on multiple levels. So the communication between the cells, communication through growth factors, through cytokines, it's not happening. On the edges, we have this epidermis that's piling up. It's hyperproliferative, but it's not migratory. In the dermis, we have fibrotic tissue, which allows for bacteria not only to colonize, but to attach and form the biofilm. And then also in the wound bed, we have insufficient inflammatory response, so not robust enough. And that all predisposes chronic wounds to infection and further complication. Next slide, please. And when we looked at we and others looked at the composition of all the bacteria, so microbiome of the chronic wounds, we have shown quite a bit of overlap regardless of the type of the chronic wound. Next slide. And to no surprise, one of the most prominent colonizers, even without the presence of the clinical signs of infection, are again Staphylococcus and specifically Staphylococcus aureus. So again, different colors and different plots are showing composition of the microbiome and different genus and species from different studies, from different types of the wounds, with this dark blue at the bottom being Staphylococcus as the predominant genus, regardless of the wound type and the study or the method analyzed. Next slide, please. So let's summarize a little bit the most important and clinically translatable studies when it comes to MRSA and Staph aureus in general, and different types of wounds. So diabetic foot ulcers, Staphylococcus aureus abundance, so the amount of Staphylococcus aureus together with anaerobic bacteria were actually associated with negative outcomes of healing, so prolonged healing and mostly complications due to non-healing. Then when it comes to a deeper infection, to osteomyelitis, again, Staphylococcus and specifically Staphylococcus aureus have been identified in almost all affected bone samples. And one of the most robust microbiome study involving patients with different types of chronic wounds and almost 3,000 patients, to no surprise, often identified again Staphylococcus aureus as the most prevalent pathogen, together with Pseudomonas aeruginosa. Next slide, please. So the question is, are the chronic wound microbes, including our superbug MRSA, resistant to multiple antibiotics and antimicrobials, not only methicillin? Next slide. And what has been shown, again, in the context of diabetic foot ulcers, is that actually we have quite a lot of resistance in all the bugs populating, colonizing chronic non-healing wounds. So what we are showing here on the left, it's actually the graph with a different amount of antimicrobial resistant genes in patients, and then also their prevalence throughout the visits, throughout the 12-visit follow-ups. And then also on the right, we are showing different antibiotics and the prevalence of their resistance. It's reflected based on the size of circles. So quite a lot of the resistance to different types of antibiotics, including aminoglycosides, macrolides, beta-lactams, tetracyclines, and overall even presence of efflux pumps that are pumping out antibiotics and antimicrobials from the pathogens. Next slide, please. So why is it important to understand all of this? As Christina said, it's also very important to collect samples for cultures and determine if you are dealing with a patient infected or colonized with methicillin-sensitive Staphylococcus aureus that would be actually responsive to multiple antibiotics, or on the other side, MRSA, which actually can be perhaps sensitive to vancomycin. However, the resistance is growing. More we apply these new classes of antibiotics and different classes of antibiotics, more bacteria are becoming actually resistant, strikingly resistant to antibiotics widely used. Next slide, please. So what happens with antibiotics and the microbiome, all the bugs, in the context of the chronic wounds? So when the wounds are followed up for 12 weeks, even in the presence of antibiotics, we actually haven't seen much of the change. And this was study done with Elizabeth Grice's lab and Lizzie Hallen, where both unhealed and healed wounds and the patients that were treated with systemic antibiotics have shown quite a lot of stability of the microbiome composition. And next slide, please. So let's reflect a little bit on the mechanisms and the importance of the drug resistance, right? So if you treat this patient and there is no change in any microbe, including MSSA, MRSA, that means that bacteria are actually carrying the genes for the resistance to antibiotics and antimicrobials. And more we have the resistance, the treatment become more ineffective. The problem is that bacteria can actually share the resistant genes through the horizontal gene transfer. And that way actually even make beneficial bugs potentially very difficult and challenging to treat. Next slide, please. So we know that antimicrobial resistance and even antibacterial resistance, including antibacterials that are used for the wound care, can have really detrimental effects. So recently, FDA has banned triclosan and triclocarbon from over-the-counter antibacterial hand soaps and body washes, and these components were also used as wound cleansers, simply because when they were used, they actually push the bacteria to share more of antimicrobial and antibiotic resistant genes. So we even had the cases of methicillin-resistant Staphylococcus epidermidis due to too much of the triclosan and triclocarbon use. Next slide, please. So in a way, when you think about the wound and all the microorganisms that are populating this wound, including our MRSA and MSSA, when you apply the selective pressure, when you treat them with antibiotic or antimicrobial, this bacteria will be the bacteria that can survive in this environment, become resistant, and then they thrive. They're very quick in reproduction. In a few hours, you will have 2 logs, millions and millions more bacteria, and they will just overcome any kind of treatment. So as Charles Darwin said, the certain phenotypes will have an advantage and evolutionary benefit to survive. Next slide, please. However, we also ask if bacteria can hide inside human cells to escape antimicrobials and host response even further. Next slide. So what we have shown is that specifically Staphylococcus aureus can invade and reside inside the keratinocytes at the edge of diabetic foot ulcer. So what I'm showing here is diabetic foot ulcer and cell nuclei in blue, and Staphylococcus aureus shown in green, filling up this space inside the cells, only associated with diabetic foot ulcers, not the control foot skin. And in the middle, we also show more into details, this with really zooming in with confocal imaging and enlarging these cells. Again, the green dots are present very close to the center of the cell, to the nuclei of the keratinocytes. So even when we isolated bacteria with the specific approaches from the epidermis of diabetic foot ulcers, from inside the cell, we actually show high numbers of bacteria, high colony-forming units, more in the epidermis than in the dermis. Next slide, please. So MRSA, even if we grow it as a biofilm or just as a planktonic in a suspension microorganism, has this ability to invade the deeper layers of the skin and invade keratinocytes intracellularly. So again, we are looking at the green MRSA here. At the top, you see the potent biofilm over the epidermal edge. However, if we leave this biofilm and we don't remove it by any interventions, MRSA goes further down to the cell and invades the cell. At the bottom, we are actually looking at large keratinocytes with its surface stain in orange. DNA from the keratinocytes is in blue, and then all these green dots are MRSA thriving inside the cells, inside the human keratinocytes, either if originated from biofilm or from the suspension planktonic form. Next slide, please. So why is this important? Once inside the cell, you actually need way higher concentrations of antibiotic to kill intracellular MRSA. Click, please. And this way, actually, the MRSA can actually cause the persistent infection. So perhaps in this patient Christina was showing, although the wound looked fine, there was some MRSA around lingering inside the cell, hiding from antibiotic, hiding from these neutrophils and macrophages, and waiting for this moment to actually come back and cause this complicated persistent infection. Next slide, please. So how do we overall achieve the better healing outcomes? Next slide. One of the studies that followed the microbial composition throughout the time, again, coming from Elizabeth Grice's lab, has shown that we actually need a lot of changes, dynamic changes in pathogen composition to assure successful wound healing. So whenever you see the constant dark red, means the composition of the microbiome was the same. Perhaps it was too much of Staphylococcus aureus, maybe too much of Pseudomonas, and these wounds did not heal. And some of these patients actually, and non-healing wounds resulted in major amputation. And then bottom of the graph, as we show more of the changes, more of the colors, meaning that on a different weekly visits, the composition of all the microbes in the wound was very dynamic in changing. That was actually associated with healing. Next slide, please. And then when the patients were subjected to debridement, and when we look how effectively debridement changes all these pathogens, it was actually shown that if debridement introduced quite robust change and dynamic of the microbiome, then the wound healed. And it was actually successful debridement causing the healing. If debridement did not change microbial composition efficiently, then the wound remained unhealed. Next slide, please. So in a nutshell, to wrap up all the clinical cases or all the science behind MSSA, MRSA, and the microbiome, we can say that it's really up to the balance between the pathogens and the host. It's very crucial to make informed clinical decisions when choosing antibiotics and antimicrobials to eliminate pathogens or the wound colonizers, because this increases the risk of selection of the resistant pathogens, and repetitive debridement in conjunction with optimized therapy to also boost up host response is the key for successful treatment, healing, and elimination of our superbugs. Thank you all. And with this, we can move on to any questions.
Wow, thank you, Christina and Irena. It was great talks from both of you. I am happy to take any questions, but in the meantime, maybe it would be nice to talk a little bit on some of the pearls of today's speakers' talks. Catching symptoms early may be a really good strategy, as well as following the time principles of wound healing. And from Christina's talk, we also understand that understanding the correct debridement and repetitive debridement is important. And from Irena, we also take home message as MRSA using several different types of strategies to create it, from secreting exotoxins to specific adherence for allowing them to host cells, or by escaping B-cell attacks, as well as a very interesting research study on showing that they use internalizing themselves into keratinocytes to escape host defense mechanisms and micro antibiotics. So with that, I cannot see any questions, but I have some questions for Christina. Are there any specific debridement methods that you recommend to the, like the care practitioners?
Great question, Tuba. We know that there's many ways to achieve debridement, but really, honestly, the way to remove biofilm is to get in there with a sharp instrument and literally scrape that biofilm off of the tissue. So a sharp or conservative sharp debridement is going to be the method of choice. We may choose another type of debridement like enzymatic or autolytic debridement in between those appointments just to keep the process going. But we know that those repetitive taking that instrument to the wound is the most effective biofilm remover.
Thank you. And in connection to that, with Irena's, the research she presented, I was curious because Irena also emphasized the debridement early and repetitive. So Irena, do you think doing this type of debridement prevents the antibiotic resistant bacteria to enter the cells and escape? Or is there any proven research on that, connecting the debridement and the intracellular attack?
Excellent question, Tugba, and that's actually ongoing research. So hopefully we'll get the results that will change the practice. What one can assume and based on the preliminary data, debridement again removes this reservoir of the intracellular bacteria and removes these cells that are capable to host intracellular bacteria. So we cannot emphasize enough the benefits of debridement in terms of bringing this dynamic change in overall composition of all the bacteria that are there, and then reducing the reservoir of potentially persistent infections.
Thank you, Irena. And Kat, I guess there's no more questions.
Okay. Well, thank you, everybody, for another great presentation. And thank you for our attendees. So I wanted to thank everybody who's attending the Chronicles of Wound Healing Investigation series, brought to you by the Wound Healing Society Education Committee and Wound Healing U. And as a reminder, the recording will be available in your membership-only account on Wound Healing U in the next few weeks. And our next webinar is on February 13th, and that will be on Charcot foot deformity, to be held at 6 p.m. Eastern Standard Time. Okay, thank you all, and have a good evening. Okay, I think we can say goodnight.